Good evening, everyone, and welcome to Windham, Maine, where NPDL is live with our latest debate event. It's going to be dynamic, and we'll be introducing your moderator to guide you through tonight's event. We're very grateful that Maine DOC is allowing us to host this event here in MCC's visiting room, and we're very grateful to our two teams of amazing debaters from Boston College's Fulton Debating Society and from MCC's VoCavalry team. So you are in for a dynamic debate tonight, and we're very excited to get that started. Before we do, we'd like to acknowledge a couple of people because we're blessed to have an amazing volunteer network with the NPDL, and we have some of the greatest debate coaches across the country who volunteer their time generously to work with our incarcerated students and teach debate in these carceral settings. So, you know, I believe John Wooden's one of the greatest coaches of all time, from the legendary UCLA basketball coach, won basically a championship every year. That's a little bit of hyperbole, but I think he's one of the greatest coaches of all time. And it was John Wooden who said that a great coach can change a game, or excuse me, a good coach can change a game, but a great coach can change a life. And I have the privilege to work with people who redefine what changing lives mean every day. And it's inspirational, that the value you could bottle up. So it's just a real blessing to be in this position and to recognize one of our amazing coaches here today. So I hope that everyone will join me in welcoming Frankie Irizarry to the lectern now as our NPDL Coach of the Year. So Frank, come on up, sir.
Thank you. Thank you.
There you go, sir. Would you like to say a few
Thank
words to the folks at home?
I appreciate this opportunity to work with some fine debaters and work with the NPDL. I've been around debate for 30 plus years. And this has been one of the most rewarding debate experiences of my life. So thank you very much. Appreciate it.
Thank you, Frank. And full disclosure, Frank is the coach of today's MCC VoCavalry team. So we hope that Boston College doesn't mind that we deployed our very best coach to get these teams prepared for today's event. So we're very excited, and I'm also excited to introduce our next individual who's going to take this lectern and guide you through today's debate. Our moderator. He is someone you're going to know and recognize from these Maine Zooms. He won 2 debates when he was incarcerated here at MCC, and he actually helped us win our first community team event at the NCA conference in November of last year. So we're very honored and privileged to have an amazing individual who's contributing to both communities and at a high level. We're very proud to introduce today's debate moderator, Chandler Dougal. Chandler, come on up, sir.
Yes, hello, everyone. As Daniel just said, my name is Chandler Dougal, and I'll be the moderator for today's debate. It promises to be a good one, and you're all about to witness an unforgettable display of intellectual ability and social diplomacy in action. So the debate today is between Boston College's Fulton Debating Society and MCC's VoCavalry. The resolution tonight is: the United States should legalize physician-assisted suicide. Boston College will argue in the affirmative, supporting this resolution, while VoCavalry argues in the negative position, refuting the affirmative's case. Each debater will be judged upon the following criteria: analysis, reasoning, evidence, organization, refutation, and delivery. Our 4 distinguished judges today are Mr. Joe Gant, the Chief Judge, the Director of Debate at Lewis and Clark College, and Vice President of the American Forensic Association; Dr. William Shanahan, former Director of Debate at Fort Hays State University; Ed Panetta, former Director of Debate at the University of Georgia; and Bobby Herzberg, a Distinguished Senior Fellow for the F.A. Hayek Program for Advanced Study in Philosophy, Politics, and Economics, and a Senior Research Fellow of the Mercatus Center at George Mason University. As today's moderator, I'll introduce our debaters individually, and they will all adhere to their specified time limits. A digital timer will be displayed on screen, and speakers' microphones will be muted if they exceed their time limits. At the conclusion of the debate, our judges will tally up each team's cumulative point totals to determine the winner of today's contest. With all of that said, it is now time to start this debate. Speaking first, presenting the affirmative team's first constructive argument for 7 to 9 minutes, Mr. Ian McNabb, a senior from Nashua, New Hampshire, who is majoring in history and political science. Ian?
The topic for today's debate is resolved. The United States should legalize physician-assisted suicide. We'll begin by defining the key term of the resolution. Physician-assisted suicide is defined by attorney Abigail Dean in the Albany Government Law Review as occurring, quote, when an individual makes the decision to end his/her own life and his/her doctor assists in the termination of life, but the lethal drugs are self-administered by the patient. Physician-assisted suicide is a pejorative and inaccurate term. The patients aren't per se committing suicide, but rather they're seeking to end their life because they've been diagnosed with a terminal disease and they want the option to end their life sooner to avoid pain, suffering, and loss of dignity. Therefore, in this debate, we'll refrain from using the term physician-assisted suicide, and instead we'll utilize the term physician-aided dying, which has the same meaning and is recommended as the appropriate word choice by the American Public Health Association. Physician-aided dying, known by the acronym PAD, is currently legal in 9 states in the District of Columbia. In 1997, Oregon was the first state to legalize it, and subsequently 9 other states, Washington, Vermont, California, Colorado, Hawaii, Maine, New Jersey, and New Mexico, have passed legislation to legalize physician-aided dying. In Montana, the state Supreme Court held that PAD did not violate state law, but no legislation has been adapted to regulate it. As of today, PAD is explicitly prohibited by state law in 36 states, and a federal law passed in 1997 prohibits the use of federal funds in support of PAD. In today's debate, the affirmative will advocate that all 50 states should legalize physician-aided dying by passing legislation modeled after Oregon's Death with Dignity Act. Every state that has legalized PAD has enacted a common set of practices and safeguards. Thaddeus Mason Pope, a professor of health law at the Hamline Law School, described these numerous precautions in the Journal of Health and Life Sciences Law in 2020. Quote, all 9 U.S. medical aid in dying statutes have nearly identical conditions and safeguards. Regarding eligibility, the patient must 1, be over 18, 2, have decision-making capacity, 3, be able to take the medication, and 4, be terminally ill, meaning they have a prognosis of 6 months or less. Regarding physician practice, both the treating physician and a consulting physician must 1, confirm that the patient satisfies all the eligibility conditions, 2, inform the patient about risks, benefits, and alternatives, and 3, confirm the patient's request for the medication is a settled and voluntary decision. If either the treating or consulting physician suspects that the patient's judgment is impaired, then they must refer the patient for a mental health assessment by a third clinician. Once the physician writes the prescription, the patient may obtain the medication. The patient must ingest the drugs by herself or by himself. In addition to states legalizing PAD, the federal government should repeal its prohibition on using federal funds to support PAD. The legalization of physician-assisted dying throughout the United States is desirable for 2 reasons. First, physician-assisted dying laws are vital for upholding the autonomy of patients. In 1977, philosophers Thomas Beauchamp and James Childress published their groundbreaking book, The Principles of Biomedical Ethics, where they declared that autonomy was one of the 4 core principles of medical ethics. And it is precisely for this reason that competent patients have the autonomy to decide which medical treatments they want provided or withheld. This logic should also apply to patients making decisions at the end of their life. Lydia Dugdale of the Department of Internal Medicine at Columbia University argued in 2019, quote, patients accustomed to making their own healthcare decisions throughout life should also be permitted to control the circumstances of their deaths, unquote. Physician-assisted dying enhances the autonomy and dignity of patients with terminal illnesses. Attorney Joel Krinsky observed in the Brooklyn Journal of International Law in 2022 that providing individuals with autonomy in their own death provides important psychological benefits by allowing these individuals more autonomy, control, and choice. In fact, empirical studies of patients seeking PAD in Oregon identify the preservation of autonomy as their primary motivation. Madison Frank, Baltimore County, Maryland prosecutor, noted in the University of Baltimore Law Review in 2020 that in Oregon, the most common reasons that patients chose PAD were, quote, a loss of autonomy, 89%, unquote, and dignity, 82%. He concluded that these reasons support the finding that people simply want to control the manner of their death. A second reason to legalize physician-assisted dying is to alleviate the pain and suffering of patients. According to the final medical aid in dying data across authorized states from 2022, approximately 71.7% of patients seeking PAD were patients with terminal cancer diagnoses. Individuals with late-stage cancer endure extreme suffering that cannot be alleviated by pain medication. New York Times writer Sarah Lyle, whose mother had stage 4 lung cancer, wrote, quote, "Lung cancer is a frightening illness. In its final stages, it can make you feel as if you're drowning or suffocating. A formidable pharmacological stew of medications can help to suppress the symptoms, but no pill can take away the pain of waking up each day and remembering all over again that you're about to die." Therefore, Lyle wrote, her mother had enough and was ready to die. In Oregon, 27% of patients seeking PAD indicated their motivation was inadequate treatment of pain. If a patient is suffering as they near the end of their life, Attorney Joel Krinsky correctly concluded in 2022 that ending the suffering through the ingestion of lethal medication at the request of the suffering individual is both humane and compassionate. Despite these benefits, there are vocal opponents who resist legalizing PAD throughout the United States. One common objection is that physician-aided dying will result in the coercion and manipulation of patients. Yet, we now have extensive empirical evidence that refutes those claims. David Hoffman, a Columbia University professor and attorney, and Emily Beer, writing in Voices in Bioethics in 2023, observed, quote, "It has been 26 years since medical aid in dying was first legalized in Oregon, and today, about 20% of people in the U.S. lives in jurisdictions that permit MAID. Those states now benefit from decades of experience, evidence, and reporting, demonstrating that legislation can permit MAID while aggressively protecting all patients from coercion, manipulation, and harm. Given the copious evidence, concerns about abuse do not justify opposition to legislation that is effective and safe." Another discredited claim is that legalizing physician-aided dying will result in a slippery slope into allowing euthanasia. However, this has never happened in any nation or U.S. state that has legalized PAD. Jordan Potter of the Cleveland Clinic and Center for Bioethics stated in 2019, "The empirical evidence suggests there is no observable slippery slope in the legislation of physician-aided dying to acceptance and legalization of active euthanasia in any of its forms. There's literally been no occurrence of this slippery slope in nations, states, or territories where PAD is legally practiced, but active euthanasia is legal. While active euthanasia is legally practiced in the Netherlands, Belgium, Colombia, Luxembourg, Canada, all of these nations either legislated PAD and active euthanasia simultaneously or legislated active euthanasia without PAD, meaning that active euthanasia legislation has never evolved from PAD legislation. There are several territories where PAD is legal, but active euthanasia is not, including Switzerland and the U.S. states of Oregon, Washington, Montana, Vermont, California, Colorado, and the District of Columbia. None of these territories that allow PAD have transitioned to allow active euthanasia. Switzerland has legally practiced PAD for over 3 decades, with no move towards active euthanasia. Oregon, which just celebrated the 20th anniversary of their Death with Dignity Act, with no move towards active euthanasia. That's simply not going to happen. At the end of the day, terminal disease comes with a million indignities, both large and small. Diseases like cancer are inextricably linked with a loss of bodily autonomy and self-control and comes with incredible pain. The least we can do is offer them some of that control back, allowing them to determine the circumstances of the end of their life. Thank you.
Thank you, Ian. Now providing the cross-examination for the negative team from Northern Maine, a tutor here at Maine Correctional Center who's working towards his bachelor's in mental health and human services, Mr. Jared Sherwater.
So, what proportion of physicians are adequately trained to diagnose mental stability?
Obviously, it would have to be somebody who has specific training in that. I don't have the specific numbers in front of me, but evidently, for it to be legally permissible, it is required that they be qualified to make that kind of.
Okay, so isn't that a key element of implementing your proposal in a safe way? Shouldn't details like that be nailed down?
Not necessarily. Again, that's the kind of thing where there are plenty of people who are capable of doing that kind of mental evaluation and are willing to do it. They haven't had a problem finding people who are willing to do that kind of evaluation in states where they've legalized it thus far.
Thank you. Do you believe that patients whose decision-making is diminished should be able to legally commit suicide?
No, I don't. And that's exactly what we're saying. All the PAD legislations have required you to be able of capably making your own decisions in a mature and educated way. That's the whole point of the legislation.
Okay. So what evidence do you have that patients whose decision capacity is negatively affected by depression will be successfully screened out by your proposal?
At the end of the day, that's the importance of the third clinician, right? If either of the people believe that there is a depressive aspect and they're not making a decision logically, then that third clinician will come in. And it is important to remember that you need to be within 6 weeks of dying of a terminal illness. So that kind of narrows down the overall pool of people that's eligible
Okay.
quite a bit.
What percentage of physicians support federal establishment of legalized suicide?
I'm not necessarily sure, but again, we're not legalizing suicide. We're legalizing physician-aided dying in the specific case of people who have suffered from terminal illness.
Okay, so I noticed you didn't cite any source or anything like that. You don't have any information on that. Okay, so your plan involves establishment of legalized suicide. We'll go with that. Is that your source applicable to the debate given, and you don't address any issue from like a federal level for that?
Again, it's not legally assisted suicide. The
Okay.
whole point is that it's people who have terminal illnesses who are seeking to have a little more control over the end of their lives. So I think that it's important to remember that this has already been successfully rolled out in
Mhm.
several states, and that we're just suggesting it be done along those lines and according to that model.
Okay. So is suicide a good thing? Yes or no?
I think that at the end of the day, at the very end of somebody's life, if they're suffering from one of those terminal illnesses, I'm incapable of understanding what that feels like, but I would assume that I would want control over how I felt in that moment when I had so little else of it in the rest of my life. And I think that in that case, it might be something that would be helpful to some people.
So is that a yes or a no?
Again, I don't feel personally capable of making that kind of determination.
Okay, so I'd ask the judges to keep in mind that the affirmative has refused to answer that question in a yes or no.
Unfortunately, that's tough. All right. Now presenting the negative team's first constructive argument for 7 to 9 minutes. From Brunswick, Maine, the head library worker here at MCC and a member of the MCC Interfaith Council, who aspires to a bachelor's degree in business administration and accounting, Mr. Blair DeMerchant.
Thank you. Although the Supreme Court has already voted unanimously twice that there is no constitutional right to physician-assisted suicide, people who want to argue for pass would say that people should have the right to autonomy. They'll argue that there will be controls to regulate the use of this option and say there is no data that would lead us to believe these measures could be abused. This is just not true. Though it might seem reasonable to allow those possibly terminal among us an alternate way out, palliative care options are available to ease the suffering of those in hospice, and the criteria of those who should receive pass would only continue to grow. An article from the Yale Journal of Biology and Medicine published in 2019 sent a survey to 1,000 randomly selected physicians. Although 60% thought pass should be legalized, only 13% said they would participate. 60% disagreed with the statement that physicians who are not psychiatrists are adequately trained to screen for depression in patients, or with the idea that physicians can predict with certainty whether a patient seeking pass has 6 months or less to live. A third believed that it would lead to euthanasia, and 46% agreed that insurance companies would preferentially cover it over possible life-saving treatments if it was legalized nationally. A high margin of these physicians don't believe they are qualified or able to accurately predict whether a person even meets the criteria of pass, and almost half believe it will be abused. Less than 8% are even willing to participate. Doesn't seem even physicians are that confident in the viability of pass implementation. Disability advocacy groups have historically been against pass. Those groups include Disability Rights Education and Defense Fund, Not Dead Yet, World Institute on Disability, and 14 others. DREDF.org states, the disability community's opposition is based on the dangers to people with disabilities and the devaluation of disabled people's lives that result from assisted suicide. Further, this opposition stems from factors that directly impact the disability community as well as all of society. These factors include the secrecy in which assisted suicide operates today even where it is legal, the lack of robust oversight and the absence of investigation of abuse, the reality of who uses it, the dangers of legalization to further erode the quality of the U.S. healthcare system, and its potential for other significant harms. Pass's most profound injustice is that it violates human dignity and denies equality before the law. Every human being has intrinsic dignity and immeasurable worth. For our legal system to be coherent and just, the law must respect this dignity in everyone. It does so by taking all reasonable steps to prevent the innocent of any age or condition from being devalued and killed. Classifying a subgroup of people as legally eligible to be killed violates our nation's commitment to equality before the law, showing profound disrespect for and callousness to those who will be judged to have lives no longer worth living, not least the frail, elderly, the demented, and the disabled. No natural right to pass exists, and any argument for such a right is incoherent. A legal system that allows assisted suicide abandons the natural right to life of all its citizens. As for autonomy, not everyone who is facing the end of their life wants to give up. According to ABC News in Oregon back in 2008, after the passing of Death with Dignity, there was a 64-year-old woman named Barbara Wagner who found that her lung cancer, which had been in remission, had returned, and her only hope was a $4,000 a month drug that her doctor prescribed and her insurance company refused to pay. She was offered end-of-life care and even lethal medication for PASS. Deathwithdignity.org justifies the refusal because the drug was considered a second-line treatment, experimental, and of limited benefit with a high cost. Is this the autonomy and mercy that is advocated by the affirmative? If so, I'm sure that most would agree with me that we don't need their mercy or their selective version of autonomy either. Sounds more like coercion. Washington's Death with Dignity Act has seen a steady increase since it was implemented, according to DOH.wa.gov. A 2009 analysis shows that of 63 for the program, 47 people died. 3 were referred for psychiatric evaluation. In 2022, participation was 444. 363 died, and psychiatric evaluations were at 10. The law requires that a person is able to make and communicate an informed decision to healthcare providers. What's considered informed? The law also wants the patients to be diagnosed with an incurable and irreversible disease that will produce death within 6 months. What does that look like? Could not a person with diabetes who refuses their medication be considered to die within 6 months with an incurable and irreversible disease? Would they fit the parameters of this bill? According to the wording of the law, I would say that answer is most likely yes, and without adequate psychiatric evaluation to diagnose a sound mind, because it is not required, nor proper guardrails to prevent insurance companies from abusing and preferentially covering PASS over more expensive measures. PASS will victimize far more people than one might imagine. In the Michigan Law Review 2008, Dr. Herbert Hendon, professor of psychiatry and behavioral science at New York Medical College, Dr. Kathleen Foley, professor of neurology at Cornell University's Medical School and attending neurologist, pain and palliative care services at Sloan Kettering Cancer Center, writes, researchers have found hopelessness, which is strongly correlated with depression, to be the factor that most significantly predicts the wish for death. In his book, Seduced by Death, Doctors, Patients, and Assisted Suicide, Hendon writes, mental illness raises the suicide risk even more than physical illness. Nearly 95% of those who kill themselves have been shown to have a diagnosable psychiatric illness in the months preceding suicide. The majority suffer from depression that can be treated. This is particularly true of those over 50, who are more prone than younger victims to take their lives during the type of acute depressive episode that responds most effectively to treatment. Doctors Hendon and Foley report that when a patient who asks for PASS are treated by a physician who can hear their desperation, understand the ambivalence that most feel about their request, treat their desperation, and relieve their suffering, their wish to die usually disappears. They conclude patients requesting suicide and psychiatric evaluation to determine whether they are seriously depressed, mentally incompetent, or for whatever reason do not meet the criteria for assisted suicide. So why does it seem that the critical role of psychiatry and mental health would be overlooked? The highly credentialed Hendon and Foley seem to think these are quite necessary when considering PASS. Although cancer tops the list of all of Washington's reports, in 2009, the category of other was mixed with respiratory at 12% and underlying illnesses. In 2022, however, other stood by itself at 4%, but unlike any year before, underlying illnesses had produced a new category called missing unknown at 3% of the list. What were those? In no way should one of these reports ever include a missing unknown or an other category. Two safeguards in the face of these laws should be transparency and accountability, and a missing unknown or an other category is supremely against those aims and is also evidence of a lack of oversight. It's just 7%, right? In 2023, SB 5179 was signed into law expanding access. The 15-day requirement between oral requests was reduced to 7 days. Also, physicians, assistants, and advanced registered nurse practitioners are permitted to prescribe lethal medications. So a person is given less time to consider other options, and even nurses fit the bill when it comes to diagnosing an illness that will kill you in 6 months. Hawaii signed HB 650, which allows the same parameter for them. In Oregon, they passed HB 2279, removing the residency requirement, now allowing for suicide tourism. HO 190 has allowed the same for Vermont. This proves that once these laws take root, the fight becomes about expanding access. Lobbyists for insurance companies will have a field day. In the Princeton University Press in 2006, Neil Gorsuch, Associate Justice of the Supreme Court, has pointed out that contemporary advocates fault proponents of past for not being honest in where their arguments lead. If a doctor or nurse can decide with a patient that their life is not worth living, then it's not a far cry to say that when a patient can't physically make that decision, then a doctor or nurse should be able to make it for them. In the Oxford Heart Press Debating Euthanasia 2012, Dr. John Keown, Rose F. Kennedy Professor of Christian Ethics and the Kennedy Institute of Ethics, has said, if compassion justified us in giving a lethal prescription to a terminally ill patient on request to end their suffering, it would equally justify us in giving them a lethal injection, particularly if they were physically unable to commit suicide. It would also justify us in giving a lethal injection to a terminally ill patient who is incapable of making a request. How far might it go, you wonder? Maybe no farther than it has right now. Maybe it ends with the T4 program of 1939 Germany. The possibilities for flagrant abuse by a system driven for profit are beyond belief. Where there is a supply, there is also a demand. Miss Barbara Wagner showed us that. Though some might say there is no slippery slope, there is, and we're already on it. When we consent to a person's wish to die, we're confirming their fear that their life has run out of meaning and the world is better off without them. Our only path forward is to invest in better palliative and psychiatric care, to allow the vulnerable members in our society to know that it is our honor to assist them and be with them, to give them a reason to fight if they have a chance to live, to let them know they are not a burden to us and they are not alone, to inform them of palliative care so they understand they can die naturally and in comfort, that with 6 months left or not, their lives still have value. We should help to absolve their fear, not end their life. Once you start to kill, the meaning of life becomes ambiguous and it becomes embedded in society. Okay. Thank you.
Now providing cross-examination for the affirmative team, a senior from Los Angeles, California, majoring in philosophy and finance, Kayla Shadrick.
No.
I'm gonna set this right here.
Okay.
Okay, perfect. So I would like to start the cross-ex with palliative care. So can you please name, or do you have any statistics on the fact of whether or not it is available in rural hospitals?
In rural hospitals, I mean,
Like widespread hospitals and not just very limited city hospitals to a large amount of people?
I don't have any evidence to that at this point in time, but
Okay,
okay.
okay. And do you know that those physicians are sufficiently trained?
Statistically speaking, I would say that chances are probably not, because empirically, it would show that most physicians who, how do I word this?
Are you saying that so you're saying that physicians are probably not sufficiently trained for palliative care?
To diagnose either depression in patients
Oh,
or
no,
to be able
I'm
to
in
explain.
the palliative care
Mhm.
industry.
Yeah,
you
but
know-
they're not, a lot of doctors aren't trained to be able to tell their patients about palliative care.
Okay, so do you know what happens to cancer patients, terminally ill cancer patients, that their pain cannot be sedated or that it cannot be relieved through medication when they're in these palliative care places? Do you know what they do with those patients?
I'm sure they do what they can to help them with their pain.
Okay, so they have to make them unconscious and sedate them unconsciously.
Okay.
But we can get into that later. Can you name one instance where the slippery slope has happened before? Because in the many regions that we already have, it happening now, not slippery slope, but the PAD, physician-aided death.
As far as a slippery slope,
Yeah,
I would say Barbara Wagner. I would talk about her in my speech. She wanted to fight her cancer, and the only medication that was available to her was a $4,000 a month drug that was, it was experimental, sure, but I mean, it was her last chance and her insurance company shut her down.
So that's the only like evidence of a slippery slope that you guys have is the Barbara Wagner.
Well, I'm
Evidence
sure more will
that-
come later.
Okay. If you were in this situation, would you want to have control over ending your life in somewhere that you were comfortable, or would you rather continue to get worse and worse and worse until?
Not at the expense of people who might have the option taken away to fight, because insurance companies want to spend less money.
Okay, so you firmly take that stance that you would not want that at all. You don't think that you would want to have control over the end of your life.
I don't believe that, you know, the good of the one should outweigh the good of the many. I understand that it's difficult.
Okay.
That's
That's the time. Okay, thank you. Thank you.
Now presenting the negative team's first rebuttal for 4 to 6 minutes. From Robeson County, North Carolina, an Air Force veteran currently pursuing an associate's in theology, Mr. Chris Murray.
This resolution must be looked at logically and not emotionally. Debates relating to legalizing physician-assisted suicide in the U.S. have existed since 1870, when a non-physician by the name of Samuel Williams proposed to use anesthetics and morphine to end a patient's life. Over the next 35 years, conversations associated with this abhorrent practices plagued the U.S., resulting in the 1906 Ohio bill attempting to legalize euthanasia. The bill failed due to extreme public opposition. We've come a long way since 1906, medically and intellectually. Physician-assisted suicide was not seriously entertained then and should not be now. 118 years of progress shouldn't be vacated while revisiting a bad idea. The affirmative asserts that PAS should be enacted in the U.S. They have two fundamental principles to back up their argument: bodily autonomy and the relief of suffering. The arguments are theoretical and not practical. We can support human autonomy without supporting state-sanctioned PAS. On January 9, 2023, the Home Law Group published an article that highlighted how patients in California were subject to understaffing, failure to provide quality care and proper nursing services, failure to adequately educate patients and help them make informed decisions about their treatment plans, administering unnecessary psychotropic medications and antidepressants, antipsychotics, and stimulants without medical supervision or the patient's or family's express consent. The state of California has practiced a form of physician-assisted suicide since 2016, the California End-of-Life Option Act, but for 7 years has openly violated its citizens' autonomy. And so we ask, are these practices being overlooked by the affirmative because they didn't know? Or is the jury still out on looking for that compassionate approach for the thousands of people going through these egregious violations in this state? Our opponent's stated position in this debate articulates that the status quo reveals a reliance on the measure that may shorten the lives of by lawful means, like pain managing drugs and heavy sedation. They also suggest that legalizing PAS offers a swift, painless, and regulated alternative to life for those who combat debilitating illnesses. We contend that is a wrong approach. Considering the lack of empirical data and details, we believe that adequate palliative care and pain management, psychological, spiritual counseling are the better alternatives for terminally ill patients. Physician-assisted suicide should not be legalized on the basis that palliative care is inadequate. The legalization of PAS leads to insufficient resources being applied to improve palliative care. Patients are not satisfied with the level of care, and physicians should focus on fixing the current practices instead of prescribing a means for irreversible solutions. The affirmative have no choice but to argue that legalized PAS will make doctors more aware of the shortcomings of the present system, and it would encourage better end-of-life care in the future. However, legalization of PAS would not improve the current state of palliative services or hospice care because it is actually anti-care. Legalizing PAS will compromise the long-standing ethics that define the medical profession as a whole. The affirmative disregards that the doctors have sworn a Hippocratic oath to do no harm. And legalizing PAS would fundamentally alter our healthcare system. Hypothetically, there could be a doctor whose sole practice is to prescribe life-ending drugs. A 2015 Heritage Foundation healthcare report written by Dr. Ryan Anderson began with a crucial line from the Hippocratic Oath that states, I will keep the sick from harm and injustice. I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. This is an essential precept for a flourishing society. No one, especially a doctor, should be permitted to kill intentionally an innocent citizen. Dr. Anderson also notes that human life need not be extended by every medical means possible, but a person should never be intentionally killed. Doctors may help their patients to die a dignified death from natural causes, but they should not kill their patients or help them kill themselves. I believe this is the reality that such euphemisms as death with dignity and aid in dying seek to conceal. The affirmative may speak briefly about diving into the fear of loss of self and the decreased participation in pleasurable activities as examples of an impaired quality of life. We agree with our opponents about these things and that they exist, but we contend that a better application of palliative care would enrich and extend the lives of patients. The World Health Organization noted in August of 2020 that palliative care is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether physical, psychological, or spiritual. The results from these studies show palliative care is most effective when considered early in the course of illness. Early palliative care improves the quality of life for patients and reduces unnecessary hospitalization and the use of healthcare services. The first negative constructive Blair provided astonishing numbers that can't be overlooked. The result from a national study, Focused Death, a report of physicians' beliefs about physician-assisted suicide noted that 92% of physicians refused to participate in PAS. Yale's Journal of Biology of Medicine also affirmed that a third of these physicians had good reason to believe that this would provide an unmediated route to euthanasia and other historical atrocious acts, such as the Nazi euthanasia program. If history teaches us anything, it's that those with the power over life and death rarely wield it with integrity. Most doctors only wish to foster a will to live and to cope with illness and suffering, not to facilitate acts of suicide or create ambiguity around what constitutes medical treatment. The 4 Regional World Medical Association Symposium demonstrated that most doctors would never be willing to participate in euthanasia by fortifying their standing opposition policy towards PAS.
All right, and now presenting the affirmative team's first rebuttal for 4 to 6 minutes. A junior from Nashville, Tennessee, majoring in political science, Christopher Chi.
The negative is advocating for a cruel and miserable end of life for hundreds of Americans across the world. Perhaps that's why they're insistent on calling it physician-aided suicide, even though the wide majority of medical studies say that it should be called a physician-aided death. We are modeled off of the Oregon's Death with Dignity Act, which narrowly opens the door for physician-aided dying, which is what we are advocating for. Any of their fear-mongering about physician-aided suicide, any of their evidence about physician-aided suicide is not about our affirmative, and you shouldn't listen to it. I'll get into what they talked about. First, they said that physician-aided death is not a constitutional right. Their point is irrelevant. We've never claimed there's a fundamental right under the Constitution for physician-aided dying. Our position is grounded in philosophy, medical ethics, not constitutional law. Our argument is that patient autonomy is one of the 4 fundamental principles of medical ethics, according to philosophers Beauchamp and Childress, and that patients should have the autonomy to make end-of-life decisions. This is consistent with their right to give medical proxy instructions when to terminate life support. They made a lot of hoo-ha about patients being coerced and manipulated, but PAD laws contain safeguards to ensure the autonomy of patients and prevent coercion exploitation. Our Professor Pope evidence from the first affirmative speech lists all these regulations. Primarily, doctors have to confirm the patient has a terminal illness and has voluntarily consented to receive PAD. Doctors are required to explain the availability of alternative treatments and risks involved. There is no room for manipulation in PAD laws.
Second, we can go beyond the neg's idle speculation about what might happen as a result of PAD legalization by actually looking at what happened in the states where PAD passed. 26 years of empirical evidence back up the affirmative belief that the safeguards built into PAD legislation prevent coercion of patients at any level. Our Hoffman and Beer evidence from 2023 is the first affirmative proof. Quote, fears that medical aid in dying would overwhelmingly be used on the poor, the uninsured, the uneducated, or racial and ethnic minorities have not materialized, end quote. Our Hoffman and Beer discusses an NYU bioethicist named Arthur Kaplan, who once worried that PAD would be used in the way the negative fearmonger that it might be. However, Kaplan changed his mind after, quote, closely following the empirical evidence from early adopters, end quote. Additionally, quote, there isn't solid evidence of coercion or duplicity being exercised with respect to people who choose assistance in dying, end quote. Particularly, they talked about disability, but data from Oregon shows there's no evidence that people have been abused on the basis of ability under PAD. That's also according to Hoffman and Beer. Their article adds that, quote, most people with disabilities are not vulnerable to medical aid and dying abuse as they do not have the qualifying terminal illness or lack decisional capacity due to developmental disability and are therefore not eligible. Further, an article from the U.S. for Autonomy reveals that 79% of people who self-identify as having a disability support PAD. Finally, denying disabled individuals the right to choose life and bodily autonomy is not just paternalistic, but it's also discriminatory. They talked a lot about palliative care, but one, research shows that legalizing PAD does not decrease the use of palliative or hospice care. Our study from Nancy Kuzmal on the School for Social Work at the University of Maryland wrote in 2023 that more than 75% of people who utilize PAD were also enrolled in hospice or palliative programs. Also, PAD may increase the number of people who can access palliative care. Our Hoffman and Beer article suggests that, quote, states with medical aid and dying laws tend to have better access to palliative care than states without. This could be because PAD, as Samantha Neese noted in the Hofstra Law Review in 2023, and that, quote, public debate sparked could actually boost awareness and use of palliative care, end quote, and further, quote, has led to the advancement of palliative and hospice care, end quote. Finally, the neg's faith in palliative care as a cure-all is misplaced. Nancy Levin wrote in the Southern Illinois University Journal in 2022 that palliative care is hard to access because most physicians lack palliative care training. It's uncommon in many rural hospitals, as you talked about cross-examination. Worse, poor training contributes to, quote, negative outcomes for patient and family, end quote, in palliative care settings. It's better to promote and focus on PAD, which requires less training and makes it less likely for patients to suffer. They made an argument that many physicians don't support PAS. Again, that's irrelevant. We're PAD, we're very specific legislation, and the studies that were cited in the 1AC pretty clearly show that it is supported by physicians. They say that it violates human dignity because it means that people must be killed. But in order for there to be a right to life, there must be a right to choose not to live. The negative argues that people who are, facing an imminent death should, cheer up, try to face death with courage. That's crazy. PAD is a well thought out, well tested way to deal with death. And it's, actually thoughtful as opposed to just telling people that they should suck it up, I guess, because it's bad. They made an argument that not everybody wants to die via PAD. That's obviously true. That's why PAD's not mandatory. People must, take the drugs themselves. It's their choice, and they're informed by two physicians. They did a lot of fear-mongering about sort of alternative things that could happen. Insurance might pressure, but they're forgetting that two doctors need to approve this. The law is meant to be very conservative. If there's uncertainty about whether or not somebody has a medical condition, if there's uncertainty about whether or not a condition is terminal, they're not going to be eligible for PAD. And so their fear-mongering just shouldn't be dealt with. They say that people wish for death because they're depressed. And I think they fundamentally misunderstand the example that Sarah Lyle came in the 1AC. There are so many drugs you can pump into a person, but there's nothing you can do to remove the terrifying and fundamentally painful fact that death is inevitable. And allowing people a way out that is, safe and well-regulated is by far the best option. Finally, they made an argument about insurance companies. Obviously, insurance companies are not funding experimental drug treatments now. Additionally, the person themselves has to, administer the PAD drugs. There's no way for them to be coerced into participating in the PAD program. I rest.
We've now reached the halfway point of the debate, and leading us in opening the second round by presenting the negative team's second constructive argument for 6 to 8 minutes. From Framingham, Massachusetts, a tutor in the MCC Educational Department, working towards his associate's degree in liberal studies with aspirations for a BA in English, Mr. Lucas Miranovas.
Those in favor of the legalization of physician-assisted suicide commonly say that allowing medical practitioners to help patients end their own lives would alleviate the harm caused by the patient's pain, and that it would negate the burden put upon the families of said patients. In truth, this isn't the case. The termination of life should not be seen as a means of alleviating pain, since saving the lives of those in pain is one of the main aspects of the medical profession, especially in modern times where medical science has produced widely successful forms of palliative care for reducing pain that don't harm or end the lives of those needing relief. In my argument, I will start by covering the ethical boundaries of the medical field and how euthanasia crosses those boundaries. I'll then cover how the legalization of PAS will negatively affect those who are disadvantaged in our society, such as children and the disabled. My colleague previously mentioned that any attempted regulations within Aid in Dying Acts have in time been eroded so that almost anyone asking to die would be able to commit suicide, with little to no mental health evaluations being required to get approved for voluntary as well as involuntary euthanasia. Even if safeguards are put in place to maintain regulations, having physicians aid in the deaths of their patients goes against the ethical standards regularly instated across the medical field. These standards and ethics condemn any medical practitioners knowingly aiding in or intentionally causing the deaths of their patients. Throughout history until the modern day, those in the medical field have sworn oaths that they will help save the lives of people in need of care. The osteopathic oath, an oath commonly used in medical schools across the country, states that, quote, "I will give no drugs for deadly purposes to any person, though it be asked of me," end quote. This aspect is corroborated by the Hippocratic Oath stating, quote, "I will not give a lethal drug to anyone if I am asked, nor will I advise such a plan," end quote. Making it legal for PAS to be practiced could put physicians in a predicament where they would have to break their oaths. By putting the ethics of the medical field in jeopardy, the degradation of all boundaries set by these standards would be inevitable. The affirmative may retort by saying that regardless of legality, many physicians will still help their patients end their lives, and that legalizing PAS will allow regulations to be made to assure a smoother process. And yes, some may still give lethal aid, but all physicians would have to consider the risks not just to the patient, but to themselves and their livelihood. The cost of career and jail time is enough for the majority of physicians to refrain from assisting in their patient's suicide. My colleague previously stated that the World Medical Journal found that only 13% of physicians would be willing to euthanize their patients if legal. With such a small number of physicians willing to aid in a patient's suicide when legal, it's very unlikely anyone would be if illegal. Disability rights organizations around the world have maintained a strong stance against the legalization of euthanasia, posing that any law allowing physicians to aid in the suicides of patients would have a strong negative impact on disabled patients. These organizations, such as the American Association of People with Disabilities, the National Council on Disability, and many others, argue that disabilities are seen as a form of suffering by patients, and that this belief has led to disabilities being a qualifier for euthanasia. An article by the Not Dead Yet organization looking at the reasons used to justify euthanasia listed in the annual reports on Oregon's Aid in Dying Acts found that, quote, "Although intractable pain has been emphasized as the primary reason for enacting assisted suicide laws, the top 5 reasons Oregon doctors actually report for issuing lethal prescriptions are loss of autonomy at 91%, less able to engage in activities at 89%, loss of dignity at 81%, loss of control of bodily functions at 50%, and feelings of being a burden at 40%, end quote. They emphasize that these are disability issues. These organizations also state that disabled patients are at risk of coercion into suicide by either their family, friends, or insurance providers. For insurance providers, euthanasia is a great way to reduce the cost of helping those they insure, only costing the amount for the injection and the client's life, which they see as expendable. With the inevitability of regulations loosening over time after the law is put in place, euthanasia will likely become commonplace in the treatment of disabilities. We know this since it has happened in areas that legalized euthanasia. An article by the Heritage Foundation looking at the effects of Aid in Dying Acts gave insight into the negative effects these laws have on disabled patients by listing specific cases of patients approved for euthanasia due to their disabilities. Quote, "Diagnoses of disability are now considered sufficient grounds for death. In December 2012, Mark and Eddie Verbessem, 45-year-old deaf twins, were euthanized in a Belgian hospital after they discovered they were going blind. Nancy Verhelst, a 44-year-old transsexual Belgian whose doctors made mistakes in 3 sex change operations, was left feeling as though she was a monster. She then requested and was granted euthanasia by lethal injection," end quote. As my colleague previously stated, mental health evaluations are not needed or administered prior to approval for euthanasia. Those suffering from depression or any form of mental health disorder would now have the chance to end their life. The lack of psychiatric precautions opens the door for those who have mental anguish to take their lives without the chance to receive any help. The Belgian regulations on euthanasia were changed to allow minors to be euthanized. Many physicians in Belgium opposed, writing an open letter stating that removing euthanasia age restrictions was unnecessary, since palliative care was sufficient in reducing the suffering of terminally ill minors. Allowing minors to be euthanized will lead to a wide range of problems. One of the leading causes of death for those ranging from the ages of 10 to 24 is suicide, and the amount of adolescents dealing with mental health issues has skyrocketed. This is corroborated by the National Institute of Health, which released the 2022 National Healthcare Quality and Disparities Report, where they stated, quote, from 2008 to 2020, the rates of death from suicide among people aged 12 and over increased 16% overall, from 14.0 per 100,000 of the population to 16.3 per 100,000 of the population. Specifically, the rate for youths aged 12 to 17 increased from 3.7 per 100,000 of the population to 6.3 per 100,000 population, end quote. This report also found that, quote, in 2016, almost 20% of children in the United States ages 2 to 8 years had a diagnosed mental, behavioral, or developmental disorder. In 2018 to 2019, about 15% of adolescents ages 12 to 17 years had a major depressive episode. 37% had persistent feelings of sadness or hopelessness, and nearly 20% reported that they seriously considered suicide, end quote. Mental health and suicide are major problems for minors in the United States. Allowing minors to be euthanized, especially for issues that can be cared for without ending their lives, would be a disservice to our country's youth. In 1995, the Netherlands had 2 cases where a doctor euthanized a disabled infant to end their suffering. The parents requested this since the children were expected to live less than a year. They made the argument of medical necessity in court and were acquitted of their charges. Whether or not other countries allow this, the United States has shown that the child's right to life trumps the parents' rights when the Roe v. Wade decision was overturned. A 2005 study by the New England Journal of Medicine found that in the last 7 years before the study, there were 22 infant euthanasia cases. The 2013 Netherlands Committee on Euthanasia said that 650 infants a year should be eligible for euthanasia due to the belief that their lives would only bring them suffering. After this, the Netherlands infant euthanizations were condemned by the UN's Human Rights Committee. It is the main objective of the medical field and its practitioners to save as many lives as possible while reducing their suffering as much as possible. With this in mind, taking the lives of those deemed to be suffering does nothing to relieve their pain. We cannot say that death of people gives them relief and pain, and we only know it brings pain and suffering through grief to their loved ones. If we want to improve the lives of those who need it and reduce their suffering, then we shouldn't point them towards death. Opening the floodgate that is PAS would only lead to premature deaths of those that our medical practitioners are supposed to save. Legalizing euthanasia will ruin the medical field and destroy the lives of the most vulnerable in our society. It is for these reasons that the United States should not legalize physician-assisted suicide.
Now presenting the affirmative team's second constructive argument for 6 to 8 minutes. A sophomore from Louisville, Kentucky, majoring in political science, Avery Dobojan.
There are 4 additional benefits to legalizing physician-aided dying on a nationwide basis in the United States. First, prior to any U.S. state having legalizing PAD, there is evidence that patients illegally sought out doctors to provide them with lethal drugs. Emily Newcomb, University of Nebraska law student, noted in 2023 that, quote, before any state enacted legislation legalizing physician aid in dying, studies suggested that physician aid in dying occurred on a regular basis in the United States, end quote. Nathan Levy observed in the Southern Illinois University Law Journal in 2022 that, quote, surveys have shown that even in states where Medicaid aid in dying is illegal, some physicians still honor Medicaid aid in dying requests from terminally ill patients, end quote. However, Levy writes points out that there is no certainty that these terminally ill patients, quote, are receiving quality assistance to ensure a smooth and painless death, end quote, without having any standards and safeguards to ensure that only terminally ill patients who need Medicaid aid in dying are receiving it and that doctors are not targeting vulnerable populations. Doctors providing drugs to patients in the shadows is currently more dangerous compared to the oversight and strict procedures which exist in 9 states and the District of Columbia, who have legalized physician aid in dying. A second benefit to legalizing physician aid in dying is that it decreases the incentives for patients to attempt suicide. Sarah Gentry, writing in the George Mason Law Review in 2018, noted that if physician aid in dying, quote, is not legalized, terminally ill patients have an incentive to end their life on their own. This could have devastating consequences such as intense suffering, prolonged suffering, and trauma for their family, end quote. There is not just idle speculation. Attorney Joel Krinsky observed in 2022 that, quote, there were an estimated 1.2 million suicide attempts and 45,979 successful suicides, end quote. Of these suicide attempts, approximately 8,500 of them were adults age 65 or older. While it is impossible to quantify the exact number of terminally ill who attempt suicide every year due to the unavailability of legal pad, there are certainly a significant number. Shauna Bankston, who has a master's of bioethics from the University of Pennsylvania, stated in 2014, quote, blocking the option of a peaceful, relatively predictable, and medically supervised process does not result in suffering individuals mere retreat into silent acceptance. Instead, many such individuals attempt suicide in much more violent and often unsuccessful ways. Tragically, many of these suicide attempts lead to unnecessary pain and suffering. Andrew Botavia, an associate professor at Florida International University, related the tragic experience of three of his friends. He wrote in 2000, quote, my personal experience in support of the right to die continued to grow as a result of the experience of three of my friends with disabilities who resorted to desperate acts of suicide using a gun, a knife, and drugs because of the lack of availability of assistance from their physicians or other knowledgeable individuals. All three were able to achieve their goals ultimately, though one achieved death only after two painful suicide attempts and increased his suffering dramatically, end quote. Legalization of physician-aided dying guarantees that everyone who has terminal illness who wants to end their life can do so in a safe and dignified manner. Samantha Knies, writing in the Hofstra Law Review, concluded in 2023, quote, when someone is in unbearable pain, knows of their imminent death, and wishes to die, but physician aid in dying is not available to them, there is a chance that they will commit suicide. Would we not prefer individuals in such a position go about dying in an orderly manner with the help of a physician and with their family by their side, instead of leaving them on their own to figure out how to end their lives, end quote? A third benefit to legalizing physician-aided dying throughout the United States is that it promotes equitable and easier access for all individuals. Today, because physician-aided dying is legal in only 9 states and the District of Columbia, many individuals with terminal illness are denied the opportunity to receive lethal drugs from a doctor. Therefore, if someone lives in a state where PAD is illegal, they have to take extraordinary measures. One option is to relocate to a state where PAD is legal. This is required because most states where a PAD is legal impose residency requirements. Of course, most Americans lack the financial resources to relocate to a new state. But even if they could, this poses a tremendous burden on them. Consider the travails of Brittany Menard, who was diagnosed with terminal brain cancer at the age of 29. Madison Frank, a prosecutor on the Baltimore County State's Attorney's Office, writing the University of Baltimore Law Review, recounts her story. He wrote in 2020, quote, after being married for just over a year, Brittany underwent countless surgeries, including a partial craniotomy. A few months after her diagnosis, her doctor informed her that she likely had only 6 months to live. After many months of research, meeting with specialists, and conversations with her family, Brittany decided to end her life with physician-aided dying. Brittany's wish, however, posed to be a challenge because her home state of California had not yet passed a Death with Dignity Act. She therefore had to establish residence in Oregon in order to follow through with her wish to end her life on her own terms. After moving to and establishing residency in Oregon, she had to find new doctors, buy a new home, obtain an Oregon's driver's license, and change her voter registration. As if Brittany's life was not uprooted enough, her husband had to take a leave of absence from his job in California so he could move in with her. Most Americans are not in the financial position to take such drastic changes in their lives, end quote. The other option is for someone to travel to Switzerland, where physician-aided dying is legalized. Dignitas, a Swiss nonprofit group dedicated to providing aid in dying for terminal or severe illnesses, allows foreigners to receive counseling and end-of-life services at its facility outside of Zurich. According to Maria Mondell, writing in the Widener Commonwealth Law Review in 2022, 221 people traveled to Switzerland in 2018 for physician-aided dying services, end quote. Of course, this is a very expensive alternative. Sarah Gentry, writing in George Mason University Civil Rights Law Journal in 2018 states, quote, to die in Dignitas, the person must pay approximately $5,300. This does not include the cost of airfare, lodging, and other miscellaneous travel expenses, end quote. The status quo is unfair, as only the wealthy have an opportunity to gain access to PAD. The solution is clear. The United States should legalize physician-aided dying in all 50 states, and the federal government should repeal its ban on using federal funds to support PAD. Repealing the federal ban would enable Medicare and Medicaid to pay for the drugs used in PAD. This would make physician-aided dying more affordable for everyone. The benefits to expanding physician-aided dying through the United States were noted by attorney Joel Krinsky. Writing in the Brooklyn Journal of International Law in 2022, he wrote, quote, legalization would promote accessibility of aid in dying across the U.S. This is one of the end quote. This is one of the more controversial benefits of federal legalization, since opponents of aid would prefer to restrict the practice. Equitable accessibility to aid and dying services would help to provide all U.S. residents with even-handed opportunities, regardless of where they reside. Finally, there is an overwhelming public support for providing every terminally ill patient a right to physician aid in dying. Madison Frank, a prosecutor in the Baltimore County State's Attorney's Office, stated in 2020, quote, 7 out of 10 Americans support a terminally ill individual's right to physician-aided death, end quote. Frank noted that, quote, the concept of an individual's personal liberty is deeply rooted in a person's right to end their own life, end quote. We now have 26 years of experience with physician-aided dying in Oregon, and the evidence shows that the Death with Dignity Act in Oregon has been a total success. Marta Mazur concluded in the University of Detroit Mercy Law Review in 2020 that Oregon's Death with Dignity Act, quote, weighs the risks and benefits of PAD for each potential candidate. The voluntary nature of the act allows qualified patients to weigh their, quote, dignity, control, and peace of mind, end quote, against the pain they will endure. The voluntary aspect is crucial in promoting the goals of beneficence. This, quote, safeguard section, end quote, also enforces the optional nature of this goal by ensuring that the patient was not coerced into making this decision.
Now presenting the affirmative team's second rebuttal for 3 to 5 minutes. A senior from Portland, Oregon, majoring in political science and philosophy, Caleb Walksmooth.
So first, on to the natives' claim that this is a form of euthanasia. It just simply isn't, and removing residency requirements is not either. Certainly nowhere close to the eugenics argument that they are claiming throughout, and there is no slippery slope. In fact, the natives' intentions that to reality is at risk when they argue the slippery slope. First, their arguments may sound interesting in theory, but prefer the facts, which sharply contradict their idle speculation. Our Jordan Potter from the first affirmative should be the word on this issue. To recap, none of the U.S. states or countries which have passed PAD have slipped into legalized euthanasia. Oregon has had PAD for over a quarter century, and Switzerland has legalized PAD for over 30 years. So I must ask the negative, just when we'll see any actual concrete evidence of their slippery slope argument? Second, conditions built into PAD check slippage. Darley Pullman of the Center for Bioethics at Memorial University wrote in 2022 that, quote, specifying strict eligibility criteria has, end quote, has ensured that, quote, assisted dying is restricted to those nearing death, end quote. Third, the self-administration requirement of the PAD makes it very distinctive from euthanasia. Lilia Dugdale of the Department of Internal Medicine at Columbia wrote in 2019 that euthanasia is, quote, the administration of a lethal medication, end quote, which makes it fundamentally different from PAD, which requires patients themselves perform the action which will end their life. On to the argument from Belgium, the negative that the argument they made in Belgium. We aren't the Netherlands or Belgium. PAD is passed by the Oregon legislature and advocated for by the affirmative is much more narrow than the laws they cite in other countries. Obviously, the consequences of legislation are fundamentally different from what we are advocating for and should not be a top concern for any serious policymaker. The Netherlands and Belgium should both pass their euthanasia laws at the same time as PAD. It was not a chain or a link chain, and their laws respectively do not exclude minors under the age of 12 or anyone on the basis of age, as well as both nations allowing for euthanasia of non-terminal patients. On to the repeal to the Hippocratic Oath, and that has been violated. The negative's appeal to the Hippocratic Oath should be outright rejected. The oath was written in the 5th century BC. Many current medical practices, such as abortion and surgery, are prohibited in this 5th century document. Many medical schools do not require taking it anymore. For that reason, Samantha Neese, a lawyer with the JD from Hofstra, wrote in 2023, the medical community should shift the Hippocratic Oath as it has in the past, including on PAD. Additionally, Nice wrote that, quote, so long as proper protocol for the PAD law is followed, acting in accordance with the patient's wishes by providing them the medication they ask for is equivalent to giving them the best care. Finally, a PAD is voluntary. So if a doctor believes that PAD is bad or violates their oath, there is no mandate that they participate. Next claim is doctors may feel they're violating this oath or their own oath. In fact, the outright majority of doctors believe it should be legalized. And again, they contend that doctors don't like PAD. The negative has once again erred from the facts of the matter. They aren't looking at this logically. They are, in fact, the ones looking at it emotionally. Jacqueline Warren wrote in the UC Irvine Law Review in 2022 that studies concluded clearly show that doctors do support PAD. Quote, a study by Medscape in 2020 asked 5,130 US doctors whether aid in dying should be legalized for terminally ill patients. 55% of the doctors said yes, only 17% no. In a 2019 survey of 188 doctors, 60% thought that aid in dying should be legalized. Even for doctors who oppose PAD, there is no problem because it is entirely voluntary. So physicians who do not wish to participate do not have to. Answer to their disability arguments. Data from Oregon shows that there is no evidence that people have been abused on the basis of ability under PAD. That's according to Hoffman and Beer. Their article adds that, quote, most people with disabilities are not vulnerable to medical aid in dying abuse as they do not have a qualifying terminal illness or lack decisional capacity due to developmental disability and are therefore not eligible, end quote. Further, an article from the U.S. For Autonomy reveals that 79% of people who self-identify as having a disability support PAD. Finally, denying disabled individuals the right to choose life and bodily autonomy is not just paternalistic, but also it's just outright discriminatory. In fact, that is why the outright majority of American disability rights groups either approve of or are neutral on the issue of PAD, with only less than 20% actually opposing. Last on the issue of the poor being harmed, data from Oregon shows that only 0.6% of participants were uninsured in 2021. And in the 90s, data show that only 5% of PAD participants had any monetary factors at all. That's just not the case anymore. Lastly, on to mental health. This is from Thaddeus Mason Pope, professor of health law. If either the treating or consulting physician suspects that the patient's judgment is impaired, they must refer the patient for a mental health assessment by a third clinician. And I see my time. Thank you, moderator.
Presenting the negative team's second rebuttal for 3 to 5 minutes. Originally from Fitchburg, Massachusetts, but who grew up in Maine, a proud father of 5, about to obtain his associate's degree in liberal studies, soon to go on to his bachelor's in business management, Mr. Wayne Ramo.
Is this resolution about whether physician-assisted suicide is compassionate or morally acceptable, or is it about whether it should be a federal law is feasible? Laws are enacted for the safety of society. And with that in mind, we cannot just focus on autonomy, dignity, and quality of life. Rather, we must also look at the complex balances of safety and potential for harm or abuse. Any potential law allowing PAS is not simply affect a small number of people who have considered all the options. In reality, it will be those patients with the lowest economic class who will be forced in this decision. States already weigh the potential of PAS legislation based on their state's population, social economic situation, as well as their ideological views. Suicide assistance, sometimes called physician-assisted suicide or medical aid in dying, places already vulnerable groups at greater risk for exploitation by ultra-powerful insurance companies and their potential lobbying apparatuses. Physician-assisted suicide goes against the prevailing responsibility of the states have for protecting the lives of its citizens and fails to protect the integrity and the ethics of the medical profession. The term safeguards is used to attempt to quantify the misconceived theory that PS is a perfect answer to terminally ill people who are suffering. Sadly, no safeguards are 100% safe, and the chance for abuse and possibility for some to slip through the cracks begs the questions: how safe is safe enough? Is it acceptable for a law for the death to allow the death of one person who cannot receive expensive care options to die, just to allow others with care options the opportunity for assisted death? What ratio is okay? 1 to 10 or 10 to 1? Either way, as of right now, there is not enough data to prove with certainty that all who receive this quote treatment will have no other viable option. Autonomy and having the right to choose what treatments are utilized by a patient is fundamental to anyone seeking medical care, especially those with terminal illnesses. However, by definition, death is not a treatment. It is actually the ending of any option for treatment. Having autonomy does not instill immediate omnipotence to one's care. A noted psychiatrist and libertarian, Dr. Thomas Sayers, takes a negative position in his book, Fatal Freedom, There he characterized physician-assisted suicide as bureaucratized medical killing. More than 25 years ago, law professor Giles R. Schofield argued that legalization of assisted suicide does not empower patients, it empowers physicians. This is not only accurate, but incredibly troublesome. Currently, 40 states prohibit suicide assistance and impose criminal penalties on anyone who helps another person end his or her life. In Washington v. Glucksberg, the United States Supreme Court summed up the consensus saying, in almost every state, indeed almost every Western democracy, it is a crime to assist in suicide. The states that have assisted suicide bans are not innovations. Rather, they are longstanding expressions of the state's commitment to the protection and preservation of all human life. As my colleague stated, all physicians swear to the Hippocratic Oath, which states, I will prescribe regimens for the good of all my patients, according to my ability and my judgment, and never do harm to anyone. To please no one will I prescribe deadly drugs nor give advice which may cause his or her death. Who is at risk? Death visibly exposes the layers of our society's inequities in race, income, care, and opportunity, which greatly impact the shape of life in its final hours. It is a truth which the pandemic has underscored. Albeit it hard to see because it is so much easier to look away. The poorest have the highest levels of illness mortality rates. Poor health is not confined to those who are worst off. The WHO's Commission on Societal Determinants of Health concluded in 2008 that all levels of income, health, and illness follow a social gradient. The lower the socioeconomic position, the worse the health. The Disability and Health Journal stated in 2010 that the two professional organizations representing oncologists in California wrote, it is critical to recognize that contrary to belief, most patients requesting physician-assisted suicide or euthanasia do not do so because of physical symptoms such as pain or nausea. Rather, depression, psychological distress, and fear of loss of control identifies as key of end-of-life issues. This is born out of numerous studies worldwide. For example, a survey of 100 terminally ill cancer patients from the palliative care program in Edmonton, Canada showed no correlation between physical symptoms of pain, nausea, or loss of appetite and the patient's expressed desire of or support for euthanasia or pass. In 2004, the Journal of Palliative Medicine reported that low-income people of color may have a higher likelihood to want to take care of them at the end of their lives and have a greater desire to engage in a family decision-making consensus when making end-of-life decisions. In 2014, a publication of the oncologist Chun-Ming Chang explains how patients with lower SES score are disadvantaged due to doctors' misperceptions of their desire for the need of information and their inability to participate in treatment process. For example, terminally ill cancer patients receive significantly less positive social and emotional support and are less involved in treatment decisions, receive less treatment information, and have less control over communications. But after all this, you still want to weigh the value of human life. In my hand, I have a cost analysis report published in the National.
Both teams will now present closing remarks for 90 seconds. And we'll begin with the affirmative team, and returning to us is Kayla Shadrick.
Thank you. Physician-aided dying has a proven track record over 26 years. In the United States, the empirical evidence shows that it promotes the autonomy and relieves the pain and suffering for terminally ill patients. And there is zero evidence that it exploits patients, erodes medical ethics, or causes a slippery slope to euthanasia. The negative has repeatedly referred to physician-aided dying as physician-aided suicide, ignoring the fact that we are modeled off of Oregon's Death with Dignity Act, which narrowly opens the door for physician-aided dying, which is what we advocate for. Physician-aided dying guarantees that anyone who is sick and unbearably suffering, knowing of their imminent death, can pass away peacefully in the setting of circumstances in which they feel comfortable. What happens at the end of a patient's life is their own business. It is a travesty to force terminally ill patients to live out a prolonged and sustained decline, losing their ability to control their body when we can offer a safe, dignified way out to peace. This is the only real impact for you to weigh in this debate. At the end of the day, the negative is fear-mongering with an increasingly absurd what-if scenarios. We know from what we actually implemented laws to giving terminally ill patients with dignity will reduce suffering. Therefore, every state should legalize physician-aided dying because governments have no legitimate interest in prohibiting it. Thank you.
Now the negative team's closing remarks will be delivered by Mr. Jared Sherwood.
So our opponents specifically mentioned Oregon as an example of successful PAS legislation twice now. According to Patients' Rights Action Forum, or Fund, under Oregon's law, 85-year-old Kate Cheney was euthanized despite suffering from dementia. This was after a psychiatrist declared that she lacked the capacity to make the decision. This is the slippery slope you asked about. So do no harm. That is the Hippocratic Oath, the entire spirit of which patient safety and which the affirmative is dead set on violating. There's nothing humanizing about taking your own life or participating in someone taking theirs. This is probably why, even though some doctors support euthanasia or PAS, the number who are willing to participate in the process is drastically lower, as Blair pointed out. We already live in a world desensitized by violence. Why would we want to perpetuate the desensitization of loss of life by leaning into making suicide a socially acceptable option? We see where this leads, and we see when we look at the suicide machines already being manufactured in Switzerland, the place of suicide terrorism, not terrorism, tourism. Which these are those, by the way. Here's your concrete evidence for that. But it wasn't long ago we witnessed the abuse of the public trust by the pharmaceutical industry with the opioid crisis. We have witnessed the depth of their influence through lobbying. Euthanasia is not by any means a new concept, and there is a reason why we haven't already been doing this. The proposal is illogical and immoral, which is why legalized suicide should not be considered an acceptable policy. Thank you.
Thank you for both teams for this debate. Our judges are now tallying the scores. And so I'm going to ramble on for a minute while they do that. So first, I'd like to thank everyone who's in here in the room with us today for all the support we've received from the NPDL, Maine DOC, and Boston College. And I'd also like to thank everyone who's watching on Zoom with us for their support and all that you've done to help the NPDL as well. I participated in 3 NPDL debates, and I'd like to speak for a moment about why I think these are important, why these events are so important. When you're incarcerated, opportunity is a very, very rare commodity. Time tends not to be. And so with that, finding the right things to spend your time on, finding those good opportunities, those productive, pro-social and positive opportunities is difficult. It might be the most difficult thing people have to do while they're incarcerated. But the NPDL, debate programs, educational programs, vocational programs, all provide that opportunity that people need to turn their lives around, to become better citizens and eventually return to the community as upstanding members of it. I think that the debate program specifically teaches 3 things. Teaches critical thinking skills, and with that, research skills and the ability to formulate your argument and really understand topics at a deep level. It teaches camaraderie and, sportsmanship. It is difficult sometimes to sit in a room and talk out the ideas, not only with your team, but then eventually with an opposing team, and to remain calm and understand that you can have disagreements and you can deal with difficult topics like physician-assisted death and continue on. Finally, and the most important thing I think that debate programs offer to incarcerated people is meaning. Meaning is what gets people up in the morning. It's what gets you through your time. And it's what gives you something to look forward to every day. And without meaning, you become hopeless. And so I'd like, again, to thank Maine Correctional Center, the Maine Department of Corrections, and the NPDL for putting together these programs and these events, because they're unbelievably impactful. And I say that from both a personal perspective and seeing the effect that it's had on my former teammates here and everyone at this facility who I know is very supportive of it. So with that, I'd like to open up an opportunity. If there's anyone from either team would like to speak, they'd be more than welcome to. As we do not have any takers, I will speak about the thus far unsung hero for the VoCavalry team. The VoCavalry team has an alternate here with us today who I know assisted the team greatly in their research and preparations. Mr. Patrick Dapolito was born in Boston but grew up in Western Maine. He's currently earning a master's degree in adult education and higher learning through the University of Southern Maine. He is a proud father, and despite my better judgment, also a dear friend of mine. So Patrick, thank you for helping your team. I'm sure they appreciate it. Yeah. And I believe Danielle's still working with the judges on tabulating our results. Again, if anyone does want to come to the podium, they certainly can. Otherwise, I will continue to ramble on. Christopher, thank you.
I mean, I just have a short thing to say. I've been here twice now, and I've been up here in Maine, and I presented with the great opportunity to, intellectually spar with you all who are tenacious thinkers and have worked so hard and so well to really make this a very difficult debate to win and to prosecute. And I just want to thank you all for the time and the effort that you have put into this in preparing, and thank everyone here for coming and making sure that this is the thing that can happen, because this is such a valuable opportunity for everyone here. And I just want to say sincerely, thank you all, and thank you all.
Lucas, do you want to speak now?
Well, I just want to say that having been incarcerated for around 6 years, first in a juvenile facility where there really wasn't much for us to do, and now here where I'm starting to see more programs and more abilities for us to be able to actually learn and better ourselves, I know how much it can change people. I've seen when you don't have the things you can do, how much it can really hurt you and how much it can make you become a worse person. And I've also now, being here, have been able to see what allowing us to be able to participate in these programs and have the chance to further ourselves as humans really can help. So I'm glad to be able to do this, and I'm thankful for it. Thank you.
Thank you. Patrick, do you want to speak as well?
This is the second time I participated in one of these debates, and Chandler touched on the idea of sort of being relevant and being productive and being part of something. And that is, I can attest from my own perspective, the reality of that. Okay. I've watched on two teams now, just the camaraderie that it's built and the collaboration that it takes to put something like this on. Builds a lot more than just camaraderie. It builds character. It gives people something to do. They stay productive. It is just a wonderful opportunity. I'd like to personally thank the Maine DOC, the National Prison Debate League, for letting us do this and giving us this opportunity. Just thank you very much.
Whole team, right, did a fantastic job. So kudos to all of you.
Next time we'll go to you.
Still waiting on this first. Either one of you.
John got Fulton to try and get results.
Alrighty, like I mentioned earlier, after 14 years away from debate, last year I came back to coaching college debate, helping to reignite the program at Suffolk University, and it was very rewarding. And near the end of the year, John asked if I would judge one of these debates between MCC and BC, and it was such a powerful and transformative experience when the opportunity arose to work with these men. I couldn't pass up the opportunity, and I can honestly say, of the 168 hours I have in the week, the hour I spend with them once a week is the best hour of my week, and I really do appreciate you, gentlemen. It's been just a tremendous opportunity. And Warden, I see you back there. I don't know if these 6 men are indicative of the larger population you have here, but if they are, you're running a great ship because you've got some outstanding men up here. So thank you. Go Orange. Go Orange. All right, enough of me. John Katsoulis, come on down. The great John Katsoulis.
I'm just kind of an old broken down debate coach. I've been doing this over 40 years. I coached 3 prison teams this year. I coached the NCA community team to victory. I'm coaching the Maine women's team, who will be debating here in February. And I'm coaching a Connecticut women's team, who will be debating later in February. The most rewarding thing about coaching the incarcerated teams is they're more appreciative than my debaters. I had a debate meeting last night with my team. They were so like rude and disruptive. I told them I was going to retire. I couldn't take it anymore. When I coach the incarcerated teams, they listen, they ask questions, they're polite, and they're appreciative. I don't get that with my debaters. So I'm looking forward to retiring in 3 years, and I'll be the king of coaching all the incarcerated teams around the country. So I'd like to thank the judges for judging today. I know that you're all busy, and we appreciate you contributing to this kind of endeavor. Thank you.
Yeah, so as we still wait for the results to come in, you know, I know it's been said 100 times, including by myself, but really you can't understate how grateful, you know, we are as the incarcerated and the formerly incarcerated for these opportunities, for everything that's done here. Education, I really think is the pathway to a better life. And I know that because I've lived it. You can see a marked change in the people, you know, in incarcerated people as they go through the educational programs here, as they pursue higher degrees, or, you know, even those who are coming in to get their high school equivalency diplomas, or those who just want some vocational training, or even help with, you know, basic literacy. It's a special thing, and I'm trying not to be emotional about it, but I was here at Maine Correctional Center for a little over 2 years. And were it not for the opportunities here, my life would be significantly worse today than it otherwise is. And I would not have had the opportunity to go to grad school. I would not have the job I currently have were it not for the opportunities that Maine DOC and Maine Correctional Center gives their incarcerated residents, which is really an act of faith on their part, to allow these sorts of things, because it's not the norm across the country. And hopefully events like this help to change that. And yeah, so again, I'm just incredibly grateful to everyone who's here in the room, and for everyone who's helped make this event happen and all the other NPDL events happen. So thank you all very much. Yep.
Has Pete gotten a chance to speak yet?
Yes. So there are demands from the room for a speech from Peter Servideo.
That's what you get for forgetting my shirt.
It's coming in, don't worry. My name is Peter Servideo. I'm one of the EPCs here at the Maine Correctional Center, overseeing the education department. And I get to work with these men every day and see them grow and see them study and work. Well, they work every day in the education department. I'm just kind of there. But seeing things like tonight, seeing the debate, seeing the BC students come up, seeing how they have this mutual respect back and forth for knowledge and growth is what it's all about. And I'd like to see this program continue. I think we can definitely grow. I know each time we've done it as a facility, it takes a life of its own, and the men talk to each other, the women talk to each other, and really seeing some of the guys that come back for the second time or third time on the team, or new people coming on, like Lucas, is having you on the team is amazing. Seeing you come out of your shell this year has been just awesome. When you stood up here and talked earlier, I was like, wait, is that Lucas? And like, but to see that growth in you is really, really a great thing. And I think this program, it crosses the border, right? We break down the barriers, we go across the walls. And sometimes we'll laugh about being behind the walls and how it is like in the real world, right? Out in the jungle, I think we call it. And having you guys come in is also a huge step because, it can be unnerving to walk into a prison. You're coming in suddenly and you're like, oh, okay, here we go. But we see when we're all here that we're all people. Doesn't matter which side we're on. And so it was a pleasure having you. I'm trying to stretch this as long as possible. I know we're waiting for results. So I was born about 47 years. No, so I know Deputy Warden Arbor wanted to say a few words. So
To touch on something that Peter just said about hoping to continue the NPDL, I'd like to speak for a minute about how it started, at least from my experience of it. It was, let's see, it was the end of 2022, I believe it was, or no, sorry, it was around August 2022. And out of the blue, there was just sort of a random call for, oh, who's interested in a debate team? There was no context, no anything. It was just, oh, there's going to be a debate team. And that's because the Maine Department of Corrections had decided to partner with the NPDL to have a co-ed cross-facility debate team. And that first event that we had against MIT had residents from all the Maine facilities, both male and female. And when the time for the actual event came, we were all able to participate in that event in person together in the same room, debating MIT over Zoom. And that was also a huge, momentous thing for the department. And it's something that, probably gets overlooked and got overlooked by the people who are watching at home at the time, where they just see, oh yeah, they're all on the same team. They're all in the same room. It's not a big deal. In this setting, it's not the norm for males and females to be in the same unit at the same time or in the same room at the same time. But again, for really important pro-social events, in a safe way, the Department of Correction brings people together to be able to do that. For example, today, the women's debate team is here with us. They've been cheering us on, cheering MCC on. I said us, can't shake it. Yeah, can't get out of it.
Check out anytime you like.
Yeah. And, it's just a really cool thing. I had the experience of being incarcerated in another state, and a lot of the same opportunities are slow in coming, and hopefully that'll change, and hopefully it'll change across the country. But for now, it's an incredible thing that Maine's doing. And with that, are we still tabulating scores, I believe?
Wait, no, one more ballot, Shannon. Let's see how it's
I'm sorry, my thing won't scan, so I'm typing in. Do I have to type in all my scores and things to send it, right?
Totally.
Bobby, why don't you send directly to me in the message? I just sent you a message.
Oh,
Just
okay,
send
great.
the
Thank
decision
you.
and
I've been
can fill out
typing,
the
so I'm not.
scores. Yeah.
Okay, great. Perfect. Thank you. All right. So it is. I will turn off my thing again and type it in. It's very close, so.
All right, so it sounds like the scores are forthcoming. So before that, I guess I'll offer a last opportunity if anyone does want to speak. No, everyone's shy. Okay.
He said he'll speak. He whispered it, but I'm throwing him under the
Does he
bus.
Does he want to?
Yeah, he does.
Yeah.
He does.
Yeah, don't go over time this time.
I got you.
I apologize.
First and foremost, I like to thank and praise God. He is everything to me, and as I have grown in my journey as a man, I have learned quite a few things. The opportunities that they spoke about earlier today are very few when it comes to being incarcerated. I too was incarcerated in another state, and I had the pleasure of seeing the other side of things. So when it comes to being here at MCC, I really had to take a step back and realize that just what it meant to be blessed. Most people look at me and say, you're incarcerated and you're using those kind of words, and they squint their eyes. But what you don't realize is we're not fighting over bowls of food or chasing hissing cockroaches around. This is actually one of the better places. If I had to be incarcerated, this is where I would ask to be. These opportunities not only help change us, but they help us to become examples to the people that we love and care for. This facility gives us an opportunity to still reach out and have connection with our family. And most of us men that are here, and some of the women that are here, we have children. So, parts of our lives are never over. When it comes to the way things are going in society, and I look at you, this team, this young team, I was once where you guys were in age. And the opportunities that I've wasted, I see that you guys are really taking advantage of. And I applaud you for that. But I have younger ones that I want to see do what you guys are doing. But if they don't see dad who's in this situation, these circumstances, reaching and trying to do better, then they're not going to. So that's why I give MCC the praise that it deserves, because it affords us this opportunity to continue to grow and become better people, not for ourselves, but for the other ones that, that love us, and no matter where we are in this world, are looking up to us. So they tell me I'm long-winded and I can keep going, but hey, I just appreciate this opportunity. I appreciate this place, and I appreciate you guys for being here today.
Right, so the scores are now in. And I'd like one final time before the winners announced, just congratulate both teams on what I thought was an excellent debate and a really hard-fought debate. And with that, the winner of tonight's debate with a decision of 4-0 was Boston College. And as the winner of the debate, you're awarded this trophy as well. So if someone would like to come receive it. Right. Thank you for everyone for tuning in and watching. I'd like to turn it over to Mr. Daniel Troop from the NPDL for some closing remarks. Thank you.
Thank you all for staying tuned in and enjoying this high-level policy debate. I mean, I hope everyone appreciates at home, and obviously the folks here, exactly what you just witnessed. I mean, this is one of the most controversial subjects you could possibly have an intelligent discussion about, and it's very emotional content. So it's not just your typical cold policy. And the skill level that you saw on display today, I think, yeah, one team is getting a first place trophy, but there are no losers in attendance today. You guys did an amazing job. So you should all be very proud of yourselves and give everyone a round of applause once again. And just so everyone at home is clear, I'd like to let everyone know you can check out npdl.org, our lineup for the next few events here with Maine DOC, and our amazing teams within Maine are lined up. Next week, January 30th, we're going to have a very special event. It's our first ever integrated staff team where we have officers and residents working together as debate team members and as all teammates. So we're excited to show that and model what that looks like to the world, because we're doing some pretty special things in partnership with Maine DOC up here that we're very proud of. And we love pushing the needle on what's possible. And we love that Maine DOC is showing other DOCs what that can be through efforts like this. So we have a co-ed space. Our women's team is in attendance supporting the men's team. We have a very vibrant community. It's not just debate. It's like folks said prior to me getting up here, it's education, it's empowerment, it's humanization. And I don't think anyone here, is walking out of here. And for those that have the fortunate ability to walk out of here voluntarily tonight, without their minds being changed. And that's the beauty. I want to applaud Boston College, not just for their skill level, but honestly, like, it takes real moral and personal courage to voluntarily walk into a state prison in another state and come in here and deliver, you know, the caliber of argumentation that you saw on display. And I think it should also be noted, as special props to BC. You are now the first team in history since the NPDL's foundation, even prior to our official launch. You're the first college team to actually ever come into a prison and beat one of our teams. So congratulations. Respect. Okay. So check out npdl.org and use the free live stream links to check out our Harvard event, which will be against our Maine State Prison team called the Convictionists, and that'll be January 30th at 6 o'clock. And then on February 6th, our amazing team from Maine's Women's Center, the Opinionated Mind Squad, who's in the house tonight, will be taking on Frank, our Coach of the Year Suffolk University squad. So we have a lot of exciting events. And then in February, we're going to have events in Connecticut and Ohio. So stay tuned, check out npl.org, and have a great, safe rest of your night. Thanks for tuning in. Take care.